Hello, everyone. I am Ira Kirschenbaum. I am the editor of the Journal of Orthopedic Experience and Innovation. I want to say that tonight's group, which excuse me, which includes Mike Freehill, Michael Redler, Rob Meislin, Sean McMillan, and Greg Kolbath as our main panelists of sorts, but we have a lot of experts in the audience. I want to make a special call out, which is very, very important to me. I will share my screen here. We have the pleasure of having ConMed, who has been a great partner with Joey in supporting some of these sessions and a number of other things. So we'll be talking a lot about a variety. You don't need to see that in me. We'll be talking a bit about BioBrace tonight. We're opening the floor to all kinds of bioaugmentation. But the most important thing, at least for us right now, is going to be tonight talking quite a bit about the multiple different uses and the expanding uses of bioaugmentation for tendons, which I think is a very exciting area. I would like to stop sharing my screen for a second. I would like to I'll start it off by asking Mike Redler. Mike, you wrote an article for us in Joey, which that's your article, right, Mike? Surgical repair and augmentation of a Achilles tendon. So
go ahead
about that. Yeah.
So indeed, you've identified it correctly. And look, we know as sports medicine docs, we will come across a lot of situations whereby we need to do soft tissue repairs. We know that the tissue is not ideal in nature. And I think that early on, and I think it's more established now, we need to think outside the box in terms of how we can best treat this. So this particular article was actually a workers' comp guy, but he was 31 years old. He ruptures Achilles tendon. He drove an 18-wheeler truck. He went to one of the workers' comp middlemen. We won't name the name Concentra. Oh, I guess I did. And he was sent, like a lot of times they do, to therapy for about 2 months because they were pretty sure that his slap foot would get better. By the time that we saw him, he had a retracted, now more chronic tear in nature. He had basically almost like a cavitation of his Achilles tendon. And I thought, we know that there are a lot of options that once you get to more of a chronic Achilles tendon rupture, how are you going to handle this? And there was a novel new augmentation tissue available, BioBrace, that we had used a bit with ACLs. We had used it with rotator cuffs. Why not Achilles tendon? And the nice thing about it is that what we were able to do is actually to create strips to fit the defect. We know that we could put suture in it. And essentially what I did was to bridge the gap, tubularize the soft tissue, which was poor in nature, with Achilles, around the Achilles tendon, so we can get some end-to-end continuity. The reason we chose it, simple. I wanted something that would give us immediate strength, because what I like to do with Achilles tendon ruptures is frankly start a progressive early range of motion program. And so that they're starting to move it very, very quickly. So we put them into a cam walker. We also wanted biology because this tissue was crappy. It was like a couple months old. And this guy, had everything against him. He's workers' comp. We all know about workers' comp patients can be challenging. It was now chronic in nature, and he had gapping and cavitation. And we started him in a cam walker 2 weeks out, kept building up his motion. And, if you look at the article, because the beautiful thing about Joey, frankly, is that you can also put some video in there. You can look and see what his motion looked like at 6 weeks after surgery, and you can see him doing a double leg hop. So this is, thank you, Ira, you are just the man. So this is literally when he just said about 6 weeks when he came out of his cam walker. And again, he's been slap footing his motion around for a long period of time. And that's the early motion we were allowed to get. And you can see this is not a big leg. So We were concerned regarding, just being able to augment it, but the BioBrace fit in there very nicely in terms of bulk. And if you go down to the next video there, you can see what he looks like now. And this is about 4 or 5 months out from surgery. That's pretty damn good. I'm pretty glad that the patient didn't ask me to try to do that as well, because frankly, it was good. And we did get a post-op MRI at 6 months, demonstrating excellent incorporation. So look, what we're looking for, and the reason this was like a home run, is we wanted immediate strength. We could start early range of motion. We wanted biology to augment what was poor tissue. And this was like an ideal situation. I'm kind of a 4-tissue guy because I've used it for an awful lot of rotator cuffs. I use it for ACLs. I've used it for ulnar collateral ligament reconstruction in the elbow. The old Saturday Night Live thing is if you get 5, you get a jacket. So I've used it for 4 different tissues, and this has been a great addition and option that can be sitting on the back table.
Well, if anyone has any comments, you can either raise your hand or just talk. We're sort of open mic here, however you want to play it. Mike Freehill, have you've used various augmentations in different parts of the body, right? What's been your experience in some of your favorite places to augment tissue in your practice?
Yeah, no, thanks, and thanks for having me, Ira. So, since we're brought up the BioBrace, I think it's a really exciting technology. I've been using different types of scaffolds and allografts for a while, like all of us have, in different surgeries and different types of deficits and tissue we're concerned with. I'll just tell you what I'm doing with the BioBrace right now. I've used it as well in 4 different capacities, augmenting rotator cuff, both augmenting massive tears that I can just get down to the medial row. And then, I think the main thing with that is how you put it down. And there's a lot of discussion around that. And I know that there's a lot of experts on here who we could learn from, and I'd give you my own take on that later. I think you can do those with partials. It's a little more, I don't think that's being done a lot, and I haven't done it a lot, but I have done it, much the way other scaffolds have been utilized. I've used it for a deltoid insufficiency. I've used it for AC joint, CC joint reconstruction. Interestingly, I did that on a Division I athlete that I got to within 2 days and only used the BioBrace shoestring. Wow. Without an additional allograft, which I think is very exciting. And I saw that patient back today at 6 weeks, and they are reduced even a millimeter less or better than the other side. That might be pushing the envelope a little bit, but it goes to show you that there's some nice integrity to that. And then, of course, there's 2 studies that are coming on the pipeline. One is just being revised for AJSM. That we did with the UCL, utilizing it in place of an internal brace suture and doing a repair. And we put it on the robot, and the results were fantastic. It's not going to outperform a suture tape, but we're not asking it to, right? We're asking for the long term, in my opinion, with this particular product or this particular scaffold. So I think you slow down the rehab in that capacity, but you're ultimately going to have, less chances for stress shielding, kind of the unknowns that might come with having a tape in long term, which I think we're going to see down the road. And then lastly, I know that some of you know about CONMED was kind enough to sponsor or fund a study where we're doing a BioBrace patch augmented onto our subscapularis repair, randomized, following anatomic total shoulder arthroplasty. We were going to add that in reverse as well, but Mike O'Brien talked me into separating those out, and I think it's probably the wise thing to do. And then using your primary outcome as strength of the subscap, not re-tears. Use it as strength, and then do a couple times where you ultrasound and look at the thickness. So I think we've all been there for those of us who have done total shoulder arthroplasty, even though, subscaps heal pretty well. We've left the operating room sometimes and we're like, I don't know, the tissue is not as great as I wish it was. And
Right.
we keep our fingers crossed. So I think there is a place and application for this in many mediums.
All right. Anyone want to comment on the use of bioaugmentation in the shoulder? Rob, where are you using most of your augmentation? Rob Meisen from NYU.
Sure. First, Ira, thank you for having me with this esteemed faculty and signing me up for the merch. I'm really into merch.
Yeah.
Um, I've been kind of using it all over. So I mean, quickly with the shoulder, like mentioned for partial thickness rotator cuff tears. I've been using it there on the dorsal side. I'm kind of experimenting a little bit on the articular side to augment it. For older patients, revisions where I want to get some additional tissue. I think one of the first things that drew me to BioBrace was the ability to pass a suture. I mean, even using a cutting needle, you have to. It's very strong. You can use a lot of those self-retrieving suture passers through it. So, kind of the sky's the limit, and the creativity that it allows you to work around is just tremendous. So, you know, for bursal side, I'll use anywhere from like a triple loaded anchor or a single roll, and then put the bursal surface BioBrace on top of it, pass it a la Joe Burns with the mulberry knot, and then tuck it over a lateral row, tie that down immediately, and then use your lateral row anchors to get a nice quasi double row repair. I do a fair amount of hip. I've been using the BioBrace to kind of bulk up a little bit of my TFL, the tensor fascia lata, for reconstructions. I think it's a great thing because it kind of gives you kind of a central core that then allows you to wrap around and kind of do the full Monty reconstruction. I'm not a big believer in segmentals, so for labral reconstruction, it's good. I've used it for some mid-substance chronic rectus femoris tears where I want to bulk up some of the mid-substance to allow some of the myotendinous area to kind of go into. And kind of moving down the pike, do a lot of ACL work. And what really drew me to BioBrace was, and I've done a few now with using the BioBrace as the repair for proximal avulsions, where I just can't get my head around using the internal brace that acts as a stress shielder. And I feel like the BioBrace is more compatible. It's more stress sharing. I mean, there's a variety of ways you can do it. You could use some kind of suspensory button to work around it, drilling up maybe a 6 millimeter kind of tunnel, and you repair it, plus the BioBrace. I got a few videos coming out on that, but I'm really excited about the potential. I think it's off-label use from CONMED, so that I don't think they really want me to push that just yet, but I'm excited that it's an alternative to your internal brace. And then for quad tendon autograft, allograft, where you don't want to take a 10 millimeter central third of a quad tendon, you can take a 9 and bulk it up, incorporate your BioBrace into it. Works out great whether you want to do that suspensory or with a bone block. The UCL I haven't tried that there, but it makes total sense given my my animosity towards the internal brace. Extra articular around the knee, I've used it for some MPFL and also for some posterolateral reconstruction. It also could be used for like a modified Lemare or ALL. So I think the sky's the limit. I think we have to obviously see how the results stand up. But so far, just anecdotally, I'm very impressed, excited. I've been working with this BioBrace now for, I'd say, 2 years now. So I'm very happy. Haven't seen any of the reactions that I saw with the Smith and Nephew Regeniten product. About 4 or 5% of patients have a little bit of a reaction to that Regeniten.
What kind of reaction do you see with that? Just sort of an inflammatory.
It's an inflammatory reaction. It doesn't happen with that. I don't know what triggers it. I don't know whether it's the PLA staples that are used or whether it's the actual product. I tend to think it's probably more the staples from the Regeniten, but I've had a few patients that have had a little bit of a low grade reaction that can kind of simmer for, I don't know, about 3 to 4 months.
It's surprising you're saying just a few patients. I think that there's an inflammatory response that seems to be frequently in patients at 3 months.
Sean McMillan, in your article that you did, you talked a little bit about the science behind some of this. Could you give us a little bit of sort of a background of what you know is the science behind this? This is your article here, The Next Frontier, Sean.
Yeah, this is again going back, at least in my own hands and Mike Friedel's hands. We've been using sort of graphs for the better part of the last decade. Regeniten, I was a huge believer in, and still am. Still use Regeniten absolutely a ton. But this to me, this was sort of literally the next frontier, as I wrote in the article. Simply because now we had the ability to add biology to strength. So one of the things that really drew me to this was I could get tissue induction with the strength, which was huge. And when you think about the amount of strength that's there, you're looking at about 140 newtons with a single strand, 280 newtons of strength doubled over. So that's significant strength. I think Joe Burns has a video where I think he wrapped it around either a weight or a chair and lifted the chair up with the 5 by 250 millimeter implant. So there's significant strength that's there. And the science behind this is we know there's a linear degradation of the strength profile over the course of 2 years. So when you think about the early healing that's most important to us, those first 3 months to 6 months, that strength is maintained, which I think is really important. And the work that's been done now by Bill Walsh and others looking at, I don't say the optimal way to implant this, particularly with the rotator cuffs, but to maximize the benefit of the BioBrace for load sharing purposes. I think a lot of that's going to be coming out soon is important because we're all learning how to sort of deal with a graft that is able to do something no graft has ever done before, which is provide strength, provide load sharing, provide biology all at time zero. So I think that's sort of where the science is, and that's what drew it to us. And you talk about biology and biomechanics. Mike mentioned the biomechanics studies that he's doing with the UCL. We did a biomechanical study looking at it with MPFL, looking at this, and I know Rob mentioned he's done this before, but that will hopefully be published later on this year. We found again the BioBrace 5 by 250 shoestring when you did a primary repair to the MPFL and then laid the BioBrace over top, very much like you would do an MPFL reconstruction, had a better stiffness profile than a semi-T, which we know certainly is important because one of the issues with semi-Ts is over constraint of the joint and patellofemoral chondrosis down the road, is particularly if it's done wrong. We found that it had the best strength profile compared to a semi-T and native MPFL, and we had less or actually a more uniform displacement module of stiffness compared to the other two. So again, these are all things we're looking at biology. We have to be very careful that we don't just do something willy-nilly. So I think the more research we can do and the more studies we can do to show the efficacy and collect our data and biomechanical testing, it's going to open doors for people because the last thing I want to do to a 14-year-old girl is give her an allograft tissue if she doesn't need it. So I think that's really important when we're looking at, again, how we're changing biology in orthopedics.
Great. I just want to
I'm sorry, I was going to say the really important thing is I got to tell you, with all the BioBrace we're using, I'm using almost no allografts anymore, and it's actually more cost effective and provides more immediate strength. And I think it actually ends up being a savings to the surgical center because of that as well.
I before we get to Greg's study, I just want Don Buford. I want to ask you. Do you think you've been around more than a week? Do you think do you think that this whole BioAugmentation push is really going to be the gold standard? Like that, maybe if you don't use it, you're missing something very important, or what's your feelings on this whole world?
I think most of us know that there's something lacking in our typical repairs that involve soft tissue healing or soft tissue to bone healing. And we've gotten to a point where most of our implants and suture are strong enough, and it's our ability to affect the biology where all the research and all the interest is heading. And the BioBrace has just come along at a real opportune time where we no longer need to have an additional suture anchor that's 2 newtons stronger, but we do need something to help our soft tissue. And I think that's just a real natural evolution. And having been there way back with Graft Jacket, a couple decades ago, when we couldn't even do it arthroscopically, to see where we are now is just fantastic. It's just exponential change. And kudos to Kevin for bringing this to market. Michael said something really interesting, which is really important because I just had this conversation with my ASC yesterday, which some people on the call may not understand, but BioBrace is classified as an implant. And that's really important. It's not a graft like a dermal graft. And it's a reimbursement issue because our center was bought by USPI, a year or so ago, and they get reimbursed cost plus a percentage for an implant. But for a graft, it's not like that. And so if you're looking at reimbursement issues, also the advantage also tilts towards BioBrace on that aspect as well. So that was a really important point that Michael kind of glossed by, but it's really important.
It's good. And Danny, go on. Yeah, you have a question going on.
Yeah, thanks. Thanks, Ira. I just wanted to share, a new observation, which actually supports the use of augmentation on the tendon and the rotator cuff. So, when we're debriding the tuberosity, there's always tissue there. And I think that one of the things that we underestimate is the amount of normal tendon that's remaining when you reduce the tendon to the tuberosity of the shoulder. So if we're over reducing something that's highly sensitive to motion, so if we take a shortened tendon already and try to reduce it to where it should belong, it's going to re-tear by default. And the second thing I try to pay attention to is the reduction of the tendon to the tuberosity, because it's also very sensitive to load. And so I think it'll be a new area where we look at and say, do we really have enough tendon to reduce it to the anatomic location of tuberosity? And do we need to lengthen the tendon? And I'd be interested in the thoughts of the other experienced shoulder surgeons in the audience if they've noticed that. But it's something that I pay attention to more now is, do we actually have the normal residual tendon depending on the chronicity of the tear? In addition to, have I reduced the tendon anatomically enough, because I know we're talking millimeters here, that could lead to a re-rupture.
Danny, years ago, Christian Gerber, I heard him talk at New England Shoulder Society meeting up in Jay Peak, one of the best meetings there is. And the thing that resonated was, he said the purpose of a rotator cuff repair should be to reduce the tendon without tension, to your point, right? So it shouldn't be about trying to get it back to the most lateral aspect of the tuberosity. It's supposed to be to get it down so it can heal in the best environment possible. And when you look at all the things that we've done over the years, whether it's Crimson Duvet, whether it's overlays with large xenografts, whether it's using the BioBrace to sort of straddle the tendon and the tuberosity, I think that's where we have the ability to do things like create neotendon and healing, and the MRIs and ultrasound studies, and Don probably has thousands of them from ultrasound wise, that you see, a year out, 2 years out, how that neotendon becomes natural is pretty remarkable. And I think that's incumbent upon us not to worry about how it looks at time zero, trying to make it look perfect, but to understand what we're doing the moment that we leave the operating room and they flex their arm.
Yeah, I think Sean's point is very important. And I think, Danny, your point is very good as well. What we know is that the recipe for failure is trying to over-reduce a retracted rotator cuff. And so I think that, there's a great, paper out there, and a lot of us use, the rotator cuff healing index. And if you have retraction, if you have poor quality tissue, if you have diabetes, if you are a smoker, those are ones that we're all going to augment. And so you sort of know that ahead of time, but you sort of like bring it to where it can go without over tensioning it. And then by augmenting it with BioBrace, and the techniques are getting better and better in that regard, I think that we're getting increased healing, increased confidence, and our ability to be able to start some early motion with them as well. But you can't over reduce them, because that's a recipe for failure.
Don, you raise your hand.
Does anyone know?
Oh, go ahead.
Go ahead.
Does anyone know if there's an objective way to measure tension? I mean, they used to have like fish scales and stuff, but this is something I've looked at with transosseous too, trying to respect biology, and measuring bone softness objectively and measuring tension objectively. The mechanical components that we talk about.
Yeah. So Brett, there was a Scully fellow, I'm blanking on his name, but he'll come back to me in a minute. But he did that study in vivo. And he basically put a tensionometer on the edge of the cuff and held it right at the medial aspect, and then dragged it over to the far lateral aspect. And it was a 5-fold difference in tension, in internal tension. And that was in vivo in humans. And so that was, where some of this initial conversation first got started with double row versus single row, where the risk if you didn't have the tissue there, was in creating fivefold increase in internal tension. And what I was going to say was these techniques that are trying to capture biology, but that are enthesopathy based, like rhodium, and there's some others, I think also run the same risk of trying to get tissue back over something that you're putting on top of the tuberosity when you may not have enough tissue. And I think for me, one of the real advantages of BioBrace has been the fact that we can treat not only the medial aspect of the tear, where we're often doing margin convergence or other things, or there's delaminations, but we're also able to bring BioBrace over the top down to the tuberosity. So we're treating not only the enthesopathy, but also the soft tissue healing side to side.
Kevin, Dr. Plancher.
So I'm listening intently, but I think, Ira, I'd like to take it back a step. I think any area in the human body that's a watershed area, doesn't matter, Achilles, rotator cuff, tennis elbow, where we don't get good blood flow, we know that we don't do as well, or the avulsion of a hamstring off the ischial tuberosity, whatever. So that's the brilliance of trying to augment things. When we focus on the shoulder, I'm more than happy to go head to head with everyone. Danny, I would never want to take it back to the footprint in my lifetime. That's why you have 70% ruptures of rotator cuffs. That's just going to fail every time. And so we want to just, like Don said and others, attentionless repair. And so I think it's great to augment. For me, you have a smoker, you have a diabetic. That's where you fail even more. That's where it's great. And the point that this has tension on it and structural, it's really a terrific additive. But I think all of these things, and I don't know, Ira, if it will be the future, it's going to come down to, I like what everyone's saying, it's going to come down to cost, because no longer do hospitals care about outcomes. And so the fact is that they just want to see that the procedure was done and you move along. And so that's the saddest part, that we tonight should really stress that this makes a difference in patient care. And we have to really be firm. And that's why it's great that the journal is publishing in this so people can do it. But I think all these augments, and there's so many out there right now, but it's great that, Kevin Rocco and ConMed now is promoting it and people are doing it and there's research to it. But it's all about vascular blood flow that helps the body heal while it's trying to heal, I think, for me. And I'm going to use it and I love it. And I hope they bring even better ways to deliver it so that we can even use it in a more facile way.
I was going to ask Greg Kobat to talk a little bit about some of the alternate uses you found, you and Emily, on your article that was in the journal here, revision clavicle fracture ORIF, but with using BioBrace. That's kind of a novel off-label use, I guess.
Thank you. Actually, this was born out of necessity. I had about two patients in a quick span who presented to me with broken hardware with a clavicle, which thought would likely have some bone defect as well. So I know there's some techniques using a Mascalay technique, iliac crest bone graft, but I decided I would like to try to use distal clavicle autograft, which has been popularized by Dr. J.T. Tokish for bone defects in the glenoid. But I thought, well, this would be great. It's right next. It's in the same, just extend the incision, take about a 2-centimeter segment of the distal clavicle, bring that over for my bone defect. But I thought about using BioBrace really as more of to recreate the periosteum and to help with some biology around it. I think I actually reached out to Don Buford about 2 nights before this procedure and said, hey, I know you've had a lot of information about BMAC, and I wanted to try to utilize that as well. So actually harvested from the proximal humerus some BMAC, and we've cut the shoelace into about 6 strips and soaked that in the BMAC prior to closure. So we have a lot of biology going on here, a lot of probably competing factors of what really made us heal. But I think the combination of the autograft, the BMAC soaked with the collagen spun. I know Don's done a lot of absorption studies, and I think it's around 300% is about how much that volume will soak it up. And then we use the little matchsticks, about 6 of these, wrap those around the bone graft and the plate, tied those down with some absorbable Vicryl sutures, and we've got some good results. So we've had 2 of these so far. I had Emily German, who was a third-year med student at the time, rotating with me, start to write this up, and she did an excellent job. And many thanks to Joey for getting this published for us after some reviews. And like I said, we've now done 2 of these and have had good success. Both these patients are young laborers, and we're back to work at around 3 months, and we've got about 6 months follow-up right now. So the label is that you can use it where any soft tissue deficit exists, and so I felt this was a good way to help reconstruct the periosteum, allow for that BMAC to be centered in the location around the bone graft. And I think this is maybe something we need to look into for more trauma or periprosthetic applications. So that's some exciting ventures down the road we'll need to look at. I know Dr. Freehill mentioned that he had used the shoestring method for the AC graft. I had used that as well, but I was not. I didn't have the cojones enough to go solely with the shoestring method. So I backed it up with a hook plate, and that was a work comp patient. I saw him back at 3 months, knowing that we'd have to take the hook plate out. And I had an opportunity to sample a little bit of the BioBrace and get some histology samples of that. So and I was able to take that down to our Clemson bioengineers and right down the street, and they've analyzed it, and it looks very promising as far as good integration, not only with the surrounding new collagen formation, but no inflammatory reaction and good vascularization at 3 month time point. So it's some exciting stuff, and it validates what we already saw with the the histology studies from the sheep and for the ACL and the rotator cuff studies that already done. So very encouraging that it's consistent with the reaction that we would want, which is early kind of infiltration, but still good. We can see the PLA fibers, so it's very encouraging in that end.
I was going to go back to Mike Freehill. Mike, in your practice, you see obviously a lot of athletes on a pretty high end at the university and elsewhere. Have you yet made the jump to change your back to sports regimen with the use of bioaugmentation, or you're waiting on that?
Oh, that's a good question. I think I'm waiting on that. I mean, the one balance I think that you have to weigh pretty heavily when you start talking about elite athletes is maybe pushing too hard, too fast when we don't know enough, because you certainly don't want to set someone back. So even though I think that a lot of this technology is really good and can help in particular cases, I think with regards to trying to speed them back, I'm a little bit cautious.
Okay. Well, awesome. Don, you wrote a message to everyone. Could you kind of elaborate on that a little bit?
Yeah, and this is something that needs to go in Joey, if you'll have me. Our absorption stuff that the
we have 8 peer reviewers on the screen right now. We could peer review as we speak.
There's my abstract right there on the right.
Okay, it's borderline. We'll take into consideration.
Yeah. So this was just done in the OR, and for me, the indication to use an orthobiologic to augment a procedure are basically the same as the indications to use BioBrace. So why not put the 2 together? The big question was, is it going to change the handling characteristics? Is it going to make the BioBrace something that won't hold a suture or that we can now pull apart? And so we did the test. We didn't really do the absorption test until we'd already done about 5 or 6 of them. But then we started with the next case we had on the docket, which was an ACL. And we found that the strip held about 3.5 times its weight in PRP and didn't change the handling characteristics or suturing characteristics at all. And I think the next case was a cuff. And so the patch didn't hold quite as much. If you do the surface area calculations, the strip actually has a lot more surface area than the patch. And I think that's, basically what the absorption was based off of. So the patch holds about 80 to 85% of its weight in liquid or in PRP. And the good thing was it didn't change the handling characteristics at all. Now, jury's still out if it's going to affect the outcomes, obviously, but yeah.
So Don, we talked about economics a little bit earlier, and I think the idea of putting PRP into these BioBraces is tremendously attractive. It's been a challenge in terms to get any coverage to not make that a loss leader. How do you do it down in Texas?
So whenever I do orthobiologics in the OR, it's still a cash pay, and it's cash pay on the patient, because I'm not really doing any surgery in the hospital. These are all ASC cases. So the BioBrace will be covered as an implant. If the patient opts to let us do PRP or bone marrow concentrate, that's still cash pay. If somebody's using a kit, and we have an agreement with the ASC, so the ASC doesn't charge anything extra. I basically have a centrifuge parked at the ASC. If I was using a particular company, I would park their centrifuge or have them bring it in that day. And I've seen that problem solved multiple ways. One is the ASC has to have all the material go through their materials management. If that's the case, then the responsibility is on us to have the ASC not upcharge our patients 3 times for a $200 kit, and just hopefully do it as a pass-through. And at that point, it's an extra $250, but it's, in the face of an operation costing $10,000, and really with a lot of data now starting to show that it's cheaper to treat these problems at time 0 than to keep going back for revisions. And, the cost is cheaper to get it right the first time. So I think the marginal cost, whoever bears it, I think it's worth it. I think we just have to figure out who can sustainably bear it.
Mike, I'd just like to sort of chime in on the economics a little bit. If you were a Kaiser Permanente, or if you're like us, where 25% of our health system is capitated in a full at risk agreement, we look at the longitudinal case of the patient, and if we know that X number percentage will fail of let's say a 3 or 4 centimeter rotator cuff, or some other reason with an ACL or in that area, we can make the case as a health system to bring these technologies in if we have the data and we have the publications that show less revision. And I agree with you right now, and this is a lecture I'm giving at OVBC, that value just doesn't have a place on the ledger line right now. That's a little bit of a problem. But on the other hand, when we start looking at this work by Don and others, which we just published 5 minutes ago, Don, in Joey, we're pretty fast, so we just took your work and published it right away. No, but the reality is that when we start publishing work that prevents revisions, gets early return to work, that's a financial gain to the system. I know it's not to the ASC at that day, but the world is going towards health systems being directly responsible for the longitudinal care. So that may be part of the answer. I'm not so sure.
Well, you're singing to the choir. Hopefully it'll be reality.
Yeah, it really will. Mike Friel, raise your hand. What do you got?
Yeah, hey, I thought some of the comments made about techniques were great, and I think Kevin Plancher really brings up some great points as well. I'd love to hear everybody's take on how they're delivering augments, and I think we would all of us who have used Regeniten would all say that a great advantage of that is the delivery system. It's very easy, it's very fast, and that's great. And now when you talk about allografts or BioBrace, how are you placing that? And I'll when you start talking about the load sharing that Sean was getting to, I think that it's different than putting it into a double row and then doing a suture bridge and jamming it into a lateral row anchor, because in those situations, at least in my experience, that it, regardless of what scaffold or allograft or whatever you're using, you can really crimp that. And I think that you can overtension, as Kevin Plancher said, that's where you set yourself up for these CHO type 2 tears. And, I've gone back to a traditional double row technique, if you will, where you're basically taking a bite of the tendon medial to your medial repair and passing those sutures through the BioBrace, and then actually either putting in a small suture anchor or leaving an escape suture out of my lateral row and putting that down. So you're tying separate, and when you turn the water off, you just let it basically parachute down onto it. You're not going smashing it down on top of the tendon. And I don't know, that to me makes some sense. You don't seem to over tension, but I'd love to hear what other people are doing.
Yeah, let's hear. What do we got with?
I would draw your attention to there's a video that Scott Sigmund put out, and there's a technique I use as well. It's a double row technique. It is very easy. You're putting 2 medial row anchors in at the articular margin. You're passing it through the rotator cuff. You're then passing it through the medial aspect of the BioBrace. And by the way, if depending on how big the tear is, I don't have any problems taking that and trimming it just a little bit, make it a little shorter. I actually then put the lateral row sutures in. You parachute it down through whatever cannula you like. You tie medially, and then you can load both in the typical zigzag fashion, the medial row sutures with the lateral row sutures, so you get great compression, and then you put it into knotless anchors, and it has become a really easy technique. It's all a matter of suture management, and some little puncture accessory portals work great, but it's become the point where it really is taking almost no more time. And I think part of that is just doing a bunch of them. And I know that, Sean, you've done a bunch of them as well. I don't know what your thought is on that.
So I've been fooling around with the BioBrace for 3-4 years now, going back to even before it was FDA cleared, and we've done it every way known to man. And I think one of the beautiful things about rotator cuffs is good technique will sometimes get us away with things that may be imperfect science. So to be fair, I'm more in Mike Freehill's camp now, where I've gone back to doing my rotator cuff gets down to the bone, however I'm going to do my repair tensionless as possible. I have sutures medial to my repair that are independent from the initial repair. So again, think about a single row with a bunch of sutures, and then I'll take those free sutures that are deep to the repair and put them through the BioBrace and bring them out lateral into, I guess you can call it technically a double row repair, but the repair was an independent repair. The second row is simply just to keep the BioBrace down out laterally. And that's stuff that's been sort of preached in some of the load sharing techniques that Bill Walsh has done, and I think he'll share that data down the road. But I think it's important to recognize, again, the more tension we put on this, and to your point earlier, Mike, about smashing it down, it looks really cool at the time, but we have to remember what we're doing, damage wise. We want this to incorporate and lay and be tensionless and help sort of take some of that force off the repair at time zero, to let it do its job and let the biology kick in.
Any other comments on? I know that Don just put.
I'll tell you, Ira. Or go ahead, Don.
No.
Go ahead, Brett. Who was that? Yeah, go ahead.
Yeah, Brett.
Hey, I was just going to say, I've done several allografts and just did a BioBrace transosseously, and there's a couple of advantages there where it's actually easier to implant things because it's like an ACL. You can pull in line on the inferior limbs and it will come down. You can pull and push at the same time, and it self tensions, and you get intrinsic double row because it's 2 fixation points, through a tunnel at the same time, simultaneously tensioning. You alleviate the over tensioning problem because you're not malleting in the lateral row, increasing the forces dramatically, and it matches the modulus of elasticity, more. And so Gerber has some work on that, like over tensioning the cuff causing fatty infiltration. With transosseous versus anchors. It also reduces the cost ceiling for use in ASC and pots it in an active marrow source.
All right, Don,
No, I think everything Brett just said is brilliant. I I do a technique very similar to what Sean was talking about, which is an independent. Okay, so basically the slide that you see here, basically an independent fixation of the BioBrace after you do your best cuff repair, single row, transosseous, double row, whatever is best in your hands. Then we do the BioBrace independently, and you just need 4 fixation points. Medial, anteromedial, posteromedial, anterolateral, posterolateral. And even in the bursoscopy position, once you take the arm out of traction, there's going to be a little bit of an increased tension on the whole construct for that matter. But the reason why this is better for me is because it's stronger. And it allows me to stress shield the native cuff repair better by having the BioBrace independently sutured.
Kevin?
So I appreciate all the technical, incredible stuff that I've heard. I just really wanted to bring it back where you started tonight, Ira, to say that BioBrace or augmentation is we're not that good as surgeons wherever we are, and that this is the technology that will hopefully make us better. And it's time that we recognize we're not that good. And so it's exciting that it's out there. And so how you do it, and technically there's brilliance that came out tonight. But I want to say, I think we have to take a step back to critically analyze that. We need to really consider these things like BioBrace, because unfortunately it's about the patient at the end of the day, and it's disappointing sometimes that we can't get the results that we can with other procedures when we're doing some of the soft tissue procedures.
Yeah, absolutely.
Ira, it's
Yeah,
Rob.
please.
I just wanted to sort of pick up on what Kevin was saying. And one of the things that I think, and it's going to also possibly channel the whole concept of tensioning. I think AI is going to have a role here in terms of having some kind of idea or give us some kind of feedback as to how much we need to tension or over tension, under tension the native tendon tear. And what I mean is that we'll get some real time measurements in terms of if you pull X amount, maybe we'll be able to correlate that with the MRI picture in the Goutallier stage in terms of what that means for the elasticity of the tendon. So I think it's going to be, a lot of this is going to be potentially software driven, where we'll be getting some feedback on our screens as to where we need to put the tendon to kind of optimize the least amount of tension and the best result. So I'm really kind of fascinated in the next 5-10 years where AI and learning from a lot of surgeons will kind of give us some additional tips in real time.
So you thinking of like a tensioner in the operating room that's connected to a computer that collects anonymous data from everywhere and gives you all this information
Yeah, I
about.
think over time they'll be able to get some kind of visual language learning just to see and correlate, why or how the failures occurred, and then kind of pick up on that and, kind of shoot us forward, kind of in a moonshot to a much higher level in terms of understanding tensioning.
Awesome. So we have just a few minutes left. I'm going to go around the horn and just ask for some final comments. I'll start with Greg. You want to give us some comments?
Yeah, certainly. I've played with it in lots of different uses. I think the advantage of this graft is that with biology and strength at time 0 and the continued strength throughout that 2-year time frame is what's appealing to me. And also, I think it's advantageous that it doesn't have a set delivery system at this point. It's allowed us to be innovative and think about this, that we're not dogmatic and having to follow one simple instrumentation path. So I think it's really allowed for a lot of innovation, as we can see here tonight. A lot of people have put a lot of thought and playing around with it, and that's intriguing. I think there's an incredible advantage also to improving the outcomes for the patient. That's the bottom line, as Kevin Blanchard highlighted, that we've got to do what's ultimately best for the patient.
Right. Excellent. Sean, you want some final comments maybe?
Listen, I believe biology and advances are the way, and the BioBrace is fantastic, and it's agnostic to implants, it's agnostic to techniques, it's agnostic to all skill levels. And this is going to be the building block of the future. Just like Regenin was one version, the BioBrace is now the best in class, and hopefully will be for a very long time, and may even build upon itself in next iterations. But I think the takeaway point is, the science and technology is real. Technique is important. Data drives adoption by everyone else besides the early adopters on this call. So we need to collect data and outcomes and continue to hold ourselves accountable to all the things that we're doing. But I think everyone on this call can say anecdotally, and with some of the data that we've collected so far, this is changing patients' lives for the better. And I'm just happy to be a part of it.
Excellent. Mike Freehold, take us home a little bit. What do you think, summary?
Yeah, so I mean, I think it's very exciting. I think with regards to augmentation of soft tissues, the ability with certain instruments or certain products, in this particular case, like BioBrace, to be able to augment so many different tissues is very advantageous. The fact that you have both a scaffold patch and a shoestring is also very advantageous because we know that there's so many different applications for those both. I think the fact that there doesn't seem to be a reactivity to this particular product, at least I haven't seen it yet. I don't know if anybody in the group has, as well as what Sean said with the importance, or Greg said, of the time zero strength. I think that's kind of a separator. So exciting times, but we got to do good studies, and we have to try to build in comparison or control groups to prove it.
Excellent. Rob, you want some final comments?
No, I just think the sky's the limit with BioBrace. I do like that concept that, whenever you have a superpower like BioBrace, there's those positive and negative. And I think the positive part is it really taps into one's creativity in terms of what one can use it and how it can be used. For instance, the other day, I've always been struck about the failure rate of some of the posterior root repairs of medial menisci in, like, say, 58, 60-year-olds. So I've been cutting out like a lifesaver type of BioBrace and kind of incorporate that into my posterior root repair with the idea that it'll kind of lessen the cutout or cheese slicing of the suture. But that said, I mean, we're all obliged to start doing better in terms of looking at outcomes and MRI studies. So I think that's going to be the challenge, is to kind of move away from case series and kind of really publish on outcomes.
Excellent. And Dr. Redler, you'll take us home as some final comments.
So this is a brilliant panel, and you've got some outstanding people on this panel, so many thought leaders. We know that as we move forward, biology reigns supreme. It's been said before. And you look, anytime you're treating a patient with challenging pathology, whether it's an ACL, whether it's a rotator cuff, whether it's an Achilles tendon, and in my hands also was ulnar collateral ligament of the elbow, it's a race. And the race is between tissue failure and healing. And what we want to do is, frankly, is to try and stack the cards in our favor. The cards in our favor is to maximize biology, but also allow for early motion. And so the ability to be able to have biologic augmentation with immediate strength is what makes us a winning type thing. And the fact that it's on the back shelf, you don't have to order it ahead of time. It sits there as what wins. And I think that if we look critically, what we want to do is get great patient outcomes, and great patient outcomes are going to be based on our ability to get things to heal. This is going to be a great addition, and our hands, BioBrace has been great for that. It's easy to use. We can put suture through it. It's not like sewing through wet toilet paper or tissue paper, which we know some of the implants are. Yes, sorry, Kevin, I just grossed you out from Fayetteville. But the bottom line is, this is where we need to head. I think that as we get better and better with implant augmentation, we're going to have a winning combination.
Well, listen, I want to thank everybody who came on. Joey is entering the end of its fourth year, and we survived by not charging authors for article processing costs, and not charging for reprints, and not charging subscriptions, but for getting collaborations from industry. And I want to thank everyone who showed up, over 112, 114 at one point in time. You joined a good club, a good group. Charles Ott, Danny Goel, Don Buford, Marty Nichols. I'm leaving people out. I'm so sorry. Kevin Brown, Paul Brunning, Kevin Plancher, Brett Sanders, everybody who showed up. I want to thank you. Never want to keep people past the time allotted. And so I'm going to say good night. And again, I'm going to keep it open. If you want some Joey swag, send us your address. We won't use your address for anything but this. And I want to thank everyone so much for showing up tonight.